Hi all, I am Dr. T Arun Thomas from Believers Institute of Renal Disease. In this short session, I am going to discuss why the management of diabetes in patients with chronic kidney disease need to be different from general patients. There are various challenges in managing diabetes in CKD. Challenge number one is CKD patients are prone for frequent hypoglycemia. There are various reasons for these frequent hypoglycemic episodes. One reason is CKD patients have decreased insulin clearance. Insulin is normally cleared from the kidney. Obviously, with low GFR, insulin clearance will be low, resulting in hypoglycemia. Next reason is these patients have decreased gluconeogenesis from kidney. Kidney normally contributes to 1/3 of gluconeogenesis, rest 2/3 is from liver. CKD patients have decreased feeding due to poor appetite, mainly because uremia suppresses appetite. Active metabolites of many oral antidiabetic drugs are renally excreted. These accumulate in patients with CKD, resulting in hypoglycemic episodes. Hence, antidiabetic drugs needs to be carefully selected and dose should be appropriately adjusted. Lastly, for dialysis patients, they are prone to develop hypoglycemic episodes during dialysis because dialysate most often is glucose free. The implication is that for dialysis patients, the insulin dose that is given just prior to the dialysis needs to be skipped or reduced or appropriately adjusted in time or dose to prevent these episodes. Next challenge is some CKD patients have very difficult to control blood sugar. This is because there are certain uremic toxins that can block insulin receptors, resulting in insulin resistance. Another challenge in CKD patient is that we cannot reliably use HbA1c for monitoring the glycemic status. We know that HbA1c is the gold standard for monitoring glycemic status all over the world, but this becomes less reliable in CKD because in uremic milieu there can be carbamylation of hemoglobin. The carbamylated hemoglobin interferes with the measurement of HbA1c, resulting in falsely high values. Second, a reason why it's not reliable is erythrocyte survival in CKD is less. They do not have the usual lifespan of 120 days. This results in falsely low HbA1c. Thirdly, many CKD patients are on iron or erythropoietin stimulating agents or both. This stimulates the bone marrow to produce new red blood cells. New RBCs are not glycosylated, hence HbA1c value will be less for if the patient is on iron and erythropoietin. Another challenge is that many CKD patients CKD due to diabetic nephropathy have associated diabetic gastroparesis. If they have gastroparesis, the movement of food that we take is not proper in the intestine, and this can result in alternating hypoglycemic and hyperglycemic episodes. This can be very effectively treated with prokinetics. Next difference in CKD patient is that the usual glycemic target which we consider in general population cannot be extrapolated to CKD patients. Our usual HbA1c target for general patients is 7%. The evidence for this is results from UKPDS because it prevents microvascular complications. The rationale for selecting a glycemic target should be based on the balance between the prevention of microvascular complication and risk of hypoglycemia. For CKD patients, all the main microvascular complications, that is the diabetic nephropathy and sometimes even associated nephropathy, neuropathy and retinopathy, all has already happened. We do not have an end organ to salvage. All the damage has already taken place. So we are not going to gain much with a very strict glycemic control. But As previously discussed, these patients have high risk of developing hypoglycemia. So HbA1c target or blood sugar target should be tailored for individually for each CKD patient. This is a figure given by American Diabetic Association. If patient is prone for hypoglycemia, less strict control. If the disease duration, diabetic duration is high, less strict control. Obviously, CKD diabetic nephropathy patient has long duration of diabetes. Low life expectancy, less strict control. CKD reduces the life expectancy. Important comorbidities, less strict control. CKD patients usually have other comorbidities too. Established vascular complications, less stringent control. And what will happen if we increase the insulin dose for a strict control? It results in more hypoglycemic episodes. We are not very keen for this strict control. So kidneys are already lost, risk of hypoglycemia is more. So our main aim is to get a reasonable blood sugar control without developing hypoglycemic episode. Usual target which we like for advanced CKD patients are FBS of 120 to 150 milligram per deciliter, post-meal target of 150 to 250 milligram per deciliter. We give less emphasis for HbA1c in advanced CKD. Thank you. I'm winding up.